I also would throw out the question of, I certainly see a lot of patients in a broader community setting where they're not extremely fit, and it can be a challenge, but the weekly carbopaclitaxel regimen is one that pretty much any ambulatory patient can pursue, and the fact that it's weekly gives you the opportunity for regular feedback. So just thoughts on what do you think is an appropriate regimen? In the Pacific trial, they gave a range. So would you say that there's a kind of regimen of choice, or is it a pretty broad range of what would be acceptable these days? Charu, can I start?
So I would say pre-Pacific, I was following the cisplatin etoposide regimen as a choice much more vigorously, at least in my younger, fitter, healthier patients, and reserving carboplatin and paclitaxel weekly with radiation for my older patients. And that wasn't really based out of phase 3 randomized data. That was just based out of, yes, cisplatin and etoposide has been tested in the SWOG study and showed that it was superior. However, I think post-Pacific, I do feel comfortable that I can give patients carboplatin and paclitaxel. I certainly don't want to put patients in a situation where I'm giving them cisplatin and etoposide and preventing them from receiving immunotherapy at the back end, because we do know that cisplatin is much more toxic than carboplatin. I mean, let's be real. And I do feel comfortable using it. And I think the other question is what to do about consolidation. Do we still use carboplatin and paclitaxel consolidation in with the systemic dosing post chemo RT? I've frankly given up on doing consolidation. I try and come back in with durvalumab as quickly as I can after completion of chemoradiation. There was never real randomized data to suggest that consolidation chemotherapy benefits people. I mean, there's been Japanese data that has shown us actually that consolidation does not add anything other than toxicity. So I would say that I'm much more comfortable using carboplatin and paclitaxel.
So, Haas, I'll be interested in your thoughts. I was raised in the SWOG system and really have historically preferred cisplatin and etoposide, very reasonable regimen, but not necessarily for everybody, and certainly with its challenges. For me, seeing a broader body of data, such as from the RTOG and various other studies, looking at a weekly carbopaclitaxel regimen and showing pretty comparable results has emboldened me that that's a very reasonable alternative, and that was actually the most commonly used regimen in Pacific. So, Haas, what do you think about carbopaclitaxel versus cisplatin versus other regimens? And specifically, one of the issues that I think many devotees of carbopaclitaxel have is this issue of, well, weekly carbopaclitaxel doesn't give systemic dose of chemo, and I really relied on consolidation, but now I can't, or should I?
Right. So actually that question is packed. You guys have raised several important issues.
Yeah.
Let's start from the top, right? There's no randomized data suggesting that any of the regimens that we're using is better than the other one. So it's a fallacy to say that cis-etoposide or carbotaxol or carbopam or cispam is any better than any of the other ones. We have randomized comparisons for a lot of these regimens, and we're not seeing major differences. Fact number 2, there has not been a single phase 3 study showing that any kind of consolidation before Pacific had any effect. So in fact, docetaxel was a little bit more detrimental, if I remember the Hoosier Oncology phase 3 studies. So why do you want to do the consolidation? Now, the weekly carbotaxel poses a special issue, right? Why do we do the 2 big doses of carbotaxel afterwards? Is because of metastatic spread, the cancer cells being around, and you want to make sure you have some systemic therapy. But that's all pre-Pacific data. The reality is that we live in a little bit of a data-free zone right now because Pacific did not look at that specific question. And let's keep in mind that 28% of patients who got on Pacific, if I again recall correctly, got induction chemotherapy with full-dose chemo before they went to the concurrent arm of the study. So what does all of this mean for my practice? I still like to give full-dose chemo if I can, because I sort of believe in that metastatic elimination, so I like cystotoposide. I'd use it a lot. For my non-squamous patient population, I kind of like the platinum pemetrexed approach. I don't see anything wrong with that. It gives you 2 or 3 full doses. But if I do weekly carboplatin, I'm with you, I don't feel the need to give the 2 big doses after chemo-RT, and I'd rather start the durva earlier. Would I fault somebody? Let's assume you want to do the weekly carboplatin, and you still want to give the full dose. Well, that takes 6 weeks. You're still within roughly the window of Pacific because you're in that magical 42-day time period that they allowed. The issue that we all have is that we are interpreting the Pacific trial as indicating that the sooner you start the durva, the better the outcome, where in reality, it might be that the patients who got started on durva sooner had better performance status, had less burden of disease, they tolerated the concurrent part of everything a little bit easier. That's why they got the durva a little bit earlier, so there was a natural selection.
So to step back a bit, there has been a post hoc analysis that looked at time initiating durva after completion of chemoradiation and showing that the best results were in the patients, the relatively small subset in the initial iteration of the trial who started within 2 weeks. That was not broadly feasible, and they had to widen the eligibility to a 6-week interval. And so, yeah, I agree with you that a lot has been made of this best results in the patients earlier, but that's not a clear cause and effect. It's not a randomized finding. There's very good reason to think that those patients are not the same patients who required 5-6 weeks to be at that point.